nurse staffing ratio, I call for safer practice. My name is Sylvia, and I'm going to start with nurse staffing ratio. What is this? And nurse staffing ratio refers to the number of nurses or nursing per hour, number of patients or patient days, or vice versa. Sometimes nurse staffing is discussed in terms of skill mix. And why we are concerned with this topic, it's a role in patient safety. It has impact on the standard of nursing care we deliver, the hierarchy of patients who need more nursing care, and understaffing depletes morale and decreases job satisfaction.
My name is Cicely Samuels, and I'm going to talk about some of the factors that affect staffing. There are numerous of factors that contribute to the problem of inadequate staffing. These include, but are not limited to, managed care, reduced insurance reimbursement, and nursing shortage. To solve these problems, the healthcare facilities rely on voluntary and mandatory overtime. Interestingly enough, overtime does not solve the problem, but eventually compounds the problem to even more, which could eventually lead to serious consequences, from dangerous adverse effect to fatality for the patient. This is due to the fact that workers have already worked their designated tour of duty and may be tired, but continue to work additional hours, further exacerbating their tiredness and fatigue. Chronic fatigue and poor global sleep quality are common among healthcare personnel, as per AHRQ 2007. In my daily practice, on several occasions, I have seen nurses pass out on the job from fatigue secondary to overworking. Staffing shortage has serious consequences in compromising the care and safety of patients. Ever so often during change of shift, it is endorsed to my tour by the previous tour that a heparin lock needs to be reinserted, a wound dressing change was not done, a follow-up on blood pressure or blood sugar was not done after prior treatment on a patient who had an abnormal reading previously. Sometimes, even the medication is administered way beyond the scheduled time as an effect of staff shortage and excessive workload. Connie Garrett, in her article, The Effect of Nurse Staffing Pattern on Medication Errors and Nurse Burnout, spoke of a nurse who worked an 8-hour shift back-to-back, who near the end of her shift administered the wrong medication, which resulted in the patient's death. The nurse was held criminally responsible for the patient's death as a result of her error. In a study by Roger et al., data indicated that work duration, overtime, and number of hours worked per week had significant effect on error, with the likelihood of making an error increasing with longer work hours. For instance, nurses were 3 times more likely to make an error when working shift that has 12.5 hours or more.
Good evening, I'm Fanny, and I'm going to talk about the effects that the workload has on nurses. For one is burnout. Studies show that 1 in 5 nurses will experience burnout in their nursing career and will ultimately leave the profession. Job dissatisfaction is another one. 40% of hospital nurses reported being dissatisfied with their job. Job-related stress is a result of short staffing, excessive workload, and overtime requirements. The effects of nurses, another effect of nurses is increased job demand. Nursing role not clearly defined. For example, the nurse has to be the pharmacist, the nurse has to be the transporter, the nurse is the receptionist, the nurse is the housekeeper. As we say at work, nursing is the only job that's not clearly defined. Everybody else can say, oh, that's not my job, I don't have to do this, Miss, I'm not putting this bed, I'm not supposed to. We have to do everything. This results in nurses not being able to come to work, nurses calling in sick, because when you work so hard, 2 days, you have 8 patients, you have 9 patients, you're tired, you can't go to work the next day. Then you deal with reprimanding. This also results in frequent turnover, because you hire the new nurses, they come and they don't want to do that kind of work, so they leave, then you keep hiring. Signs of symptoms of burnout, it have a negative outlook on work and personal life. Inability to express empathy to patient and staff, physical and emotional exhaustion. Nurses can make excessive mistakes with medication and documentation. They feel as if you're accomplishing nothing, no matter how hard you try. They also sacrifice patient safety in order to complete tasks. There's an increased risk in patient falls, there's an increased risk in bed sores, because you can really turn the patient Q2 hours, even though a lot of times you would document Q2 hours, you're not really doing the Q2 hours turning. The financial impact, we have low productivity, malpractice costs, turnover costs, unsatisfied clients, and adverse events. Patient fall incident, who is to blame? It is estimated that more than 10 patients out of 1,000 fall every day while hospitalized. Unfortunately, nurses get the blame, even if the incident is accidental and beyond someone's control. Excuses are not allowed for nurses. They are held accountable for what happens during their shift. Do nurses get sued? Of course they do. Typically, when nurses get sued, they are named with a larger group of defendants, which often includes a hospital and physician. Oftentimes, defense of these cases hinges on the quality of documentation. Unfortunately for us, sometimes the documentation is inadequate because of excess workload.
Hello, my name is Inna, and let's see what is actually can be done. This topic on staffing, it's still not well researched, but let's look at some potential implications. There are many debates going on, and one of these is, should government be involved in the problems facing healthcare staffing? But what does government know about running ICU, oncology unit? Answering this question could be the key to uncovering the real problem and choosing the right solution. To find the answer requires sorting through a lot of data, information, interpretation, generalization, attitudes, and belief systems. It also means looking beyond the concept of staffing to the whole of healthcare and the many ways staffing impacts the overall system. So let's look why would nurses want to hand over their power to make staffing decisions to the government? The hypothesis offered here is a simple one, that the barriers to having optimal staffing in healthcare are trust and behavior. Perhaps what got us into the situation of asking government to intervene in the world of healthcare staffing is the inability of management and staff to work together effectively to design the most effective approach to staffing. Nursing thinks they have to fight or work around finance to get what they need, and finance thinks nursing is not capable of putting forth accurate needs. What's actually true is that the system is broken, not necessarily the individuals on both sides trying to do their jobs. Fixing the system requires close collaboration between nursing and finance. The starting point must be to understand the underlying issues, establish trust, and engage in behaviors that will leverage the best thinking on both sides.
Hello, I'm Tenzing Zompa, and I'll be talking about legislation and nursing. the effect that legislation has on the nurse staffing ratio, and what efforts are being made to bring changes. The two primary drivers for changing the nurse staffing ratio is the need to improve patient outcomes, and the second one is to make the working conditions better for nurses. As my colleagues Vanya and Ina pointed out, obviously we are working in very difficult and very stressful situations, and there's a need for legislation to bring about some changes. So there are three proposals in terms of how changes can be brought about. One of them is the starting of the mandating of nurse staffing ratios, and this has been implemented in California with success, and this has been done since 2004. A research study by Aiken et al. Found that when they compared California and Pennsylvania and New Jersey, where they have no mandated staffing ratios, and California where it is being implemented, they found a lower burnout rate and job dissatisfaction in hospitals where the California mandated ratio existed. They also found that patient outcomes were better for patients, and changes in patient conditions were picked up sooner, and care was better for patients once they were discharged. Since 2006, Florida has also implemented the minimum staffing ratios in nursing homes. The second plan, which is endorsed by the ANA, is called Acuity-Based Staffing Plans, and this is being implemented in 7 states, in Texas, in Nevada, Ohio, Oregon, Illinois, Connecticut, and Washington. But there is a problem in terms of implementing this nationwide because of the fact that regulating bodies want a standardization of practice, and with Acuity, it's hard to enforce standardization. The last proposal is having public disclosure of staffing patterns so that the public the patients and all the other consumers of healthcare will be allowed to get reports of the staffing levels in the hospital. However, although this is good for transparency, but then again, in some places where people they go to community hospitals, they don't have the kind of choices in the hospitals they go to, and this might also create a more competitive market, so that instead of basing staffing on the needs of the patients, staffing will be based on the staffing in the other hospitals in the area. In New York State, they enacted this legislation in 2009. In the PowerPoint, there's also a map in regards to when staffing plans and ratios have been enacted, and this is since March 2009. There's a more updated map which is available on the ANA website, and the ANA website also conducted a poll online, and they found that 72.5% nurses believe that staffing is not sufficient. And there are stories of nurses who work in the Northeast region who talk about the conditions they work in, where they have nurse-patient ratio to 1:8, 1:9, and it's really stressful, and they're overworked and understaffed, and the fact that nurse staffing ratio is based on census alone, and which of course makes care very unsafe for all our patients and also for the staff who work in these conditions.
Hi Professor, my name is Charlene Kellis, and I'll be talking about how can we promote nursing teamwork without the implementation of staffing ratio in New York. The New York legislators are considering the Safe Staffing for Quality Care Act, a nurse staffing ratio bill, A0092 and S4553 for hospitals and nursing homes that is supported by the New York State Association and the New York Public Employees Federation. The proposed ratio will be more stringent for some units in New York compared with California's Safe Staffing Ratio law, which went into effect in 2004. While New York nurses await legislation decisions, they can promote and advocate group teamwork by implementing the team model system. The team model system has many benefits. 1, group teamwork leads to a higher staff job satisfaction. It boosts staff retention. It lowers staff turnover and vacancy rates. It also increases nursing productivity and decreases nursing stress level. It offers support to inexperienced nursing staff, and foremost, it increases patient safety, improve patient quality of care, and greater patient satisfaction. Working as a team, when nurses work as a team, it is conducive to nurses and also to increase patient outcome and safety. Thank you.
Happy holidays, get well soon.
It was nice working with you.
Take care.